Hello and welcome to the Straits Times panel discussion on living with COVID-19, Singapore's new normal. I'm Audrey Tan, science correspondent at the Straits Times, and I'll be the moderator for today's discussion. It has been a year and a half since the coronavirus upended the status quo. And just when we thought we were on the brink of returning to life as it was before the pandemic, new variants of the coronavirus have put Singapore and many other countries back on heightened alert. Yesterday, Prime Minister Lee Hsien Loong said that if the virus is here to stay, Singapore would have to learn to deal with it, just like it does with dengue or influenza. But what would life be like in this new normal? We have three guests with us on the show today. Each is an expert in domains relevant to the pandemic, from vaccines to public health and the coronavirus itself. They are Dr. Danny Soon, Chief Executive Officer at the Consortium for Clinical Research and Innovation, Singapore. He is also a member of the Ministry of Health Expert Committee on COVID-19 Vaccination. Professor Lisa Ng, Executive Director of the Agency for Science, Technology and Research Infectious Diseases Labs, and Professor Teo Ying, Dean of the Swee Hock School of Public Health at the National University of Singapore. Thank you for joining us today. So before we begin today's discussion, let's hear from the experts on their thoughts on yesterday's announcement. So Professor Teo, maybe you could kick us off. We were told yesterday that life with the coronavirus could be like living with dengue or influenza. And this is quite a departure from the previous posture where Singapore tried to eliminate the virus. So what are your thoughts on this?
So thanks again for having me on. Actually, this isn't something new. That for quite a while now, public health experts, both locally and internationally, have already said that the world will not be able to eradicate the coronavirus completely. And we do need to look at what are the long-term strategies to allow us to coexist with COVID-19 while having the least impact to our lives and enable us to live lives as close to what we were doing before COVID-19 as possible. And this actually isn't something new that we have to do. Because if we look at what has happened to polio, to measles, mumps, diphtheria, tetanus, or even TB, this have been all infectious diseases that used to cause widespread infection in the communities many years back, decades ago, even in Singapore. But we don't even think too much about it now. And the reason it's because we have vaccinations to protect us from this now, and most of them we receive within the first 2 years of our lives. So we don't even think too much about it, nor do we really wonder about the safety or efficacy of these vaccines. Most of us accept that these vaccines work and are safe. So this is exactly where we are aiming for, what our long-term game plan of living with COVID-19 will look like, that at some point, we will continue to see COVID-19 being included as part of our national immunization schedule for both adults and children. And perhaps we will need regular booster shots from time to time to make sure we continue to be protected, especially against any new emerging variants. And once in a while, I think there will be people who will be infected, just like TB, just like tetanus now. Some people will be infected despite having been vaccinated. But for most of these infected people, because it will be mild now and because it will be asymptomatic, we may not even know that we have been infected. And crucially, infection with COVID-19 upon vaccination no longer bears a real risk of being hospitalized or potentially dying from it. And this is now part and parcel of our lives, of how we would live with COVID-19, just as how we have lived with polio, measles, and TB. So when that happens, then there is a real chance that many of the COVID-19 restrictions that we currently have in Singapore will be lifted.
Thank you, Prof. Teo. That was quite a good overview about this long-term game plan that Singapore is looking at. But before we probe that into detail, maybe Professor Ng, you could just give us a bit of an idea about the reasons behind this heightened alert. I mean, you studied coronaviruses for your PhD, and that was like long before this group of viruses topped people's minds. And yesterday we heard Minister Gan Kim Yong saying that we are in a race with this virus. And I guess that is in reference to the new variants that we are seeing. So how do you think all these new strains are contributing to the resurgence of cases today?
Well, thank you for having me. Now, it is not unusual to deal with all these mutations, as the coronavirus is a very large RNA virus. So it is bound to have occasional mutations as the virus continues to spread and evolve. So it is like a tug of war between host and pathogen. But it is actually very important to note that while most mutations are actually harmless and do not necessarily cause more severe diseases in healthy people. Now, currently, the data have indicated that while this particular mutation is more transmissible, now it is not necessarily more deadly. So eventually, COVID-19 will become endemic like the common cold and other respiratory infections as mentioned by Professor Teo. However, with all this that is going on, now it is very important to ensure effective containment of the virus. It's also very important for scientists to stay updated on the sequences of all the emerging new variants so that our detection systems and assays will remain robust and sensitive enough to detect the virus even in asymptomatic patients.
Okay, thank you, Professor Ng. You gave quite a good summary of basically the new strains that we are seeing now, and of course one of the most the variant of concern that people are talking about is B1617. We have seen a lot of vaccine makers coming forward to say that, hey, their vaccines are still effective against these new variants that we are seeing today. So Dr. Soon, maybe you can share with us, that this heightened alert is happening amid the rollout of Singapore's vaccination campaign. And we heard yesterday that Singapore may actually open the doors to new vaccines. So can you tell us what is the difference between the two vaccines that has been approved in Singapore and the others on the WHO's list?
Sure, thank you, Audrey, and thanks for having me. So, as you know, the Health Sciences Authority of Singapore has actually approved two messenger RNA vaccines. These are the Pfizer-BioNTech vaccine as well as the Moderna vaccine. And so what the Ministry of Health announced yesterday was that they're going to open up this thing called the Special Access Route, which actually is a mechanism that is already pre-existing, whereby the HSA can approve medicines to be brought into Singapore, those that are not officially approved under the normal approval routes for special circumstances. Right. So the precondition of this, as I understand it, is that these COVID vaccines then also have to be on the WHO emergency use listing. And the three vaccines that are on the emergency use listing, which Singapore has yet to approve, are the two adenovirus vaccines, which are the Johnson & Johnson, as well as the Oxford AstraZeneca vaccines. And the fifth one, which is the Sinopharm inactivated virus vaccine. So what are some of these fundamental differences between these classes of vaccines? For the messenger RNA vaccines, mRNA, as I think we all have heard many times already over the last year, is that these are strands of messenger RNA which are encapsulated in lipid nanoparticles, and this is delivered as a vaccine to the host, right? So into the arm, right? And what happens is that the messenger RNA itself enters into the cells, and it instructs cells to produce certain viral proteins, in this case the spike protein. And the host, therefore the human, will have an immune response against this protein, and this is the basis for the immunity subsequently. For the viral vector vaccines, a fairly similar process where a host virus, in this case adenovirus, is inserted with the coronavirus DNA, which then, when this is delivered to the host, again into the arm of the human, this causes the production of certain proteins for which the human would mount an immune response. The last one, the inactivated virus, the Sinopharm vaccine. What happens there is that this is a actual coronavirus taken from infected patients. They are expanded, they are grown, and then they are inactivated through chemical means. And so they are no longer alive, and they can't replicate, and they can't cause disease. However, they still have around the shell proteins which are specific to this virus, and when they are given as a vaccine, the human body again mounts an immune response to these proteins, and this is the cause of the immunity.
With us about the differences between the different types of vaccine technologies, but maybe you can share with us why this is important. Why aren't the two mRNA vaccines enough? I think there were some reported cases of those who have anaphylactic conditions not being allowed to take the vaccines. So why are the alternative types of technologies important?
So there is a suggestion that perhaps the mRNA vaccines, because of the composition of vaccines, maybe not the mRNA per se, but the lipid nanoparticles may be causing some of these allergic reactions. So some diversity, be it adenovirus or protein subunits or inactivated, would be useful. And they also provide slightly different immune responses, right? So there's something that is being looked at this point is whether or not we do something called a heterologous prime boost, meaning that you give one type of vaccine as a starting prime, so to speak. And then thereafter, as we go into the future, we're giving booster shots, we give a different types of vaccine, which presents different sets of antigens in different ways, and whether they give a good immune kick, and therefore you have a broader immune coverage. So having a diversity of this is useful from that standpoint. And also the storage conditions for the mRNA, for example, at this point, they are pretty exacting. There's still some parts of the supply chain for which they need to be stored at -70 degrees. But for the viral vectors, they are much more robust in that sense. They're more stable and can be stored at fridge temperatures, for example.
That's very interesting, and as Professor Ng pointed out earlier, still lots more research that we have, Singapore has to do in the coming months. So I think vaccinations, testing, contact tracing, these are the key pillars of life in Singapore, life as the new normal. And many observers have pointed out that actions like masking up, safe distancing, vaccinations all make up a Swiss cheese approach to stopping the spread of the virus. And that means, taken alone, each measure may result in leaks or holes in the Swiss cheese, but together they could provide quite a decent block. But despite all these efforts that we've been taking for over a year and a half, here we are at the brink of another lockdown. So maybe you guys can share with us your thoughts on this. Is what Singapore has been doing enough? Professor Teo, maybe you could take this.
Right, maybe I can start. So I think it's important to remember that the measures that we put in place actually have kept the situation under control for the past 12 months since we ended the circuit breaker. And it's certainly not a matter of whether we have lifted our restrictions too early. In fact, if we compare what Singapore is doing against the rest of the world, there are a lot of comments that says that Singapore is a lot more cautious than many other countries. And in May, which is last month, there were several news reports from other countries talking about how Singapore is tightening up again because we have another wave of community outbreak. Whereas in countries like the United Kingdom and the United States, they are actually started lifting many of their restrictions. But what I found interesting was that this news report did not realize that at that time, on a per capita basis, the number of cases given the number of population each country has, Singapore's outbreak in May was actually 10 times less than what the United Kingdom and the United States were experiencing at that time. So I think if put in other words, the situation in UK and US were actually 10 times worse than Singapore's when they started lifting their measures and allowing people to mingle in pubs or not wearing their masks. Whereas Singapore, 10 times less, we were tightening our measures. So I don't think it is really a situation of Singapore being too relaxed or lifting our restrictions. But if you start to think about what could we have done better, or did we make a mistake, or is there any parts that we failed? I think it's important to remember that what has really changed is the coronavirus that we're dealing with right now, that seems to have penetrated a lot of our defenses. You talk about the Swiss cheese. The new variant is much more transmissible, and infected people now have a much higher viral load. And the incubation period now is also a lot more variable compared to the past. So someone who is infected could actually be contagious just 1 or 2 days after being infected, or they could be contagious after more than 14 days. And that's why you start to see why our 14-day quarantine or stay-home notice start failing to pick up some of the people who subsequently became infectious. So a lot of our Swiss cheese defense layers now do need to be changed to cope with the changing dynamics of these new variants that are emerging.
Thank you. But Prof. Teo, you mentioned the ever-changing nature of this virus, not just in terms of the variants that have emerged, but also in its behavior, like the incubation period and all that. But I was just wondering, is there a science to calling a lockdown? Because I mean, the nature of the virus is always changing, and on top of that, we have seen different countries imposing different kinds of measures to control the spread. Is there a kind of like a checklist of requirements before a country tightens its measures further?
So most countries will avoid a lockdown if they can, because lockdowns are economically very damaging. And I think in this current phase of what I would call CB light or phase 2 heightened alert, we have already seen some of the impact on our retailers, on our eateries. So that's what we always try to avoid. But lockdown becomes necessary when you start to realize that the situation within the community seems to be spiraling out of control very rapidly, to the point that your hospital resources starts to get overwhelmed. Because the moment your hospital resources gets overwhelmed, that's a very bad sign. And people who need oxygen, who need ventilators or intensive care units are unable to access those because the present supply are all being used up. That's when people actually start to die from a preventable condition such as COVID-19. And that is when you need to tap on the brakes and say, I need to call for a lockdown, whether it is a partial lockdown or a full lockdown, so we can allow our healthcare system to breathe and to recuperate. Now, what Singapore has done is to avoid a complete lockdown, but rather to go on a sectorial lockdown. So we look at what sectors have been affected, which housing block estates have been affected. We essentially ring fence those and say we will test this very carefully. Certain malls have been infected. We actually say we lock down those malls for a period of time. We disinfect. We try and break the chains of transmission that has been happening in those places. And by doing this sectorial lockdown, whether it is for specific locations or whether it is for specific segments, this is a way to allow the rest of society to continue without the economic damage. But otherwise, I would imagine every country would try to avoid a total lockdown, particularly when we talk about locking down schools as well, because locking down schools have a long-term impact for an entire generation.
So is it right to say that, I mean, using an analogy that came out during yesterday's press conference, it's like trying to control a fire from spreading by closing the fire doors progressively?
Very similar to that, yes.
Okay, so we all know that in Singapore, public policy decisions are made based on science. And I think by now, most of us have a basic understanding of this virus. But Prof. Ng, maybe you can share with us a bit more about the latest behind the new variants of concern. How is that contributing to more cases, and what else do we know about all these new strains today?
Well, in terms of the impact of the immune response, we are still gathering information on the human response against the different new variants. Now, at the moment, preliminary data shows that our immune systems will not respond any differently. The body's defense will be triggered, protective antibodies and T cells will be produced. Now, in children, the symptoms are usually mild, and like adults, their immune systems also will mount a protective response. Now, in terms of how these mutations could lead to the implications on the development of drugs, now it would be very important to expand the library of the different antiviral compounds, also the available clinically approved drugs that also could be used as therapies in order to ensure the effectiveness. Now, if talking about the future, Professor Teo has already alluded to this. It would be also useful for us to take booster shots that have been updated to deal with the different new variants. It is just like how the regular flu vaccine shots are updated annually.
Okay. I was wondering whether you could also share with us the human immune response in a vaccinated individual versus an unvaccinated individual. We have seen the authorities come out to say that, even though the vaccine does not actually prevent someone from getting the virus or getting sick, they could still spread it, but it prevents them from developing severe disease or requiring oxygen. So have there been any studies done about how the human response is different between a vaccinated person and those who are not?
Now, this is a very good question, Audrey. Now, typically vaccines mimic the virus. Dr. Soon has already explained the various vaccines that we have. So when one is vaccinated, the body's immune response will be triggered to react like it is being exposed to the real virus, and then will produce protective antibodies, T cells, for example. Therefore, for someone who has been vaccinated, would then have all these protective antibodies and T cells to block and neutralize the actual virus when you are exposed to it. Now, for someone who hasn't been vaccinated, so obviously the immune response will not have been triggered, and then they will not actually have these protective mechanisms when exposed to the real virus. It's like the army, you're training the army, and once they're all combat fit, and when you are actually exposed, they are ready. So for someone who has been not vaccinated, all these defenses are not actually ready.
Dr. Soon, on the vaccine note, would you be able to explain how getting more people vaccinated will actually help prevent new variants from emerging? Since what is the reason behind this heightened alert now are new variants? Could vaccinations prevent more of this from mushrooming up worldwide?
Thanks, Audrey. So, yes, I think as Prof. Ng mentioned earlier, is that the coronavirus is a large RNA virus. Therefore, it is expected that it will mutate as it passes from one individual to the next, or even within the same individual. And so, what happens in the mass vaccination paradigm is that you reduce the opportunity. The virus can't transmit so easily, it doesn't take root so easily, it doesn't pass on. And then even if it infects somebody, the duration of infection for a vaccinated person is likely to be much shorter compared to somebody who's not vaccinated. So all these reductions in exposure in terms of numbers of persons, in terms of transmissions, in terms of duration, all this will reduce opportunities for mutations to occur. So for example, if we had been able to stop the virus in Wuhan itself, before it got out, we will not be talking about B1617, or B117, right? Because it has not had the opportunity to mutate. So I think the vaccination is critical in terms of stamping out the opportunities for further mutations.
Do you think that the rollout of vaccinations worldwide and in Singapore during this period of heightened alert is affecting vaccination rates? Like, do you think people would say that, hey, all these are happening even though people are getting vaccinated, so maybe I should just hold off?
Yeah, that's a good question. I think that there are several dynamics in play. I think when there's certainly a concern that if there was no cases in a country, that the population itself may not feel so motivated to get vaccinated, right? So I think certainly when the cases ticked up a little bit for Singapore, it really calls out again the fact that this pandemic is far from over. At any time, if there's a small leak, it can very much take hold in an unvaccinated population. So I think that reinforces that the vaccination is critical. I think it does motivate people to come and get vaccinated. Now, the other thing around whether vaccinated persons who still get infection, I think clearly it caused a little bit of puzzlement amongst people. But I think on further investigation, our data is quite congruent with what we see around the world, is that vaccinations do reduce the opportunity to get infected. However, it doesn't completely remove it. But vaccinations are very effective in reducing severity of the disease. Very few people who are vaccinated get very ill from the disease. Very few people who are vaccinated die from the disease. This is many, many times more in the case of unvaccinated persons. So although you can, it is, I guess, in some way, a little bit disappointing to see that if you're vaccinated, you can still get infected and can still have some symptoms. It does very significantly reduce the risk of someone getting very ill. So I hope Singaporeans who understand this and see the data will still, get out there and go and get vaccinated.
Thank you, Dr. Soon. Based on PM's announcement yesterday, we know that vaccines. Oh, sorry, Prof. Teo, please chime in.
Hi, Audrey. Maybe I could also add a little bit onto what Dr. Soon has mentioned, because I think there's a very important message there that Dr. Soon has highlighted. Because if we just roll back to January, and Dr. Soon and his committee will probably remember having to field questions from the media that says Singapore is in a very good situation now. What is the incentive for us to come forward and take the vaccination? This was in January. And I remember some questions were also posed to the multi-ministry task force asking, why do we need to take the vaccine now when Singapore's COVID-19 outbreak is in a very good situation? And the answer given by Dr. Sun and his committee was spot on, because they highlighted that we cannot wait for an outbreak to happen before now people sit up and say, I need to go and take the vaccine. And because there is going to be a delay, if you take the vaccine today, your first dose today, at that point in time, you only take your second dose 3 weeks later, 3 to 4 weeks later. And now, of course, we stretch it 6 to 7, 8 weeks. But for the maximal effectiveness, it's always about 2 weeks after you have accepted a dose. So there is always a time lag of between 2 to potentially 10 weeks before one is optimally protected by vaccination. And imagine that you have an outbreak that is not under control, but it spreads very quickly. That's where you realize that even if you have the vaccination, you have the vaccine supply, and you now have a population that is eager to take the vaccine, you will still require a long time before the effectiveness of the vaccine takes place. And that is a very important message that I think the multi-ministry task force, Dr. Sun and his committee, when they advocated people come forward to take the vaccine back in January, there was a reason, because we knew that at some point our defenses, our Swiss cheese layers may break. And that's where having people who are vaccinated is important. And of course, with yesterday's announcement, we have seen that vaccination now is no longer just to protect, but it is also to enable us to return to a degree of normalcy in our lives.
Thank you, Prof. Teo. So as we heard yesterday, vaccines is just one pillar of living with COVID-19 amid this new normal. The others includes testing and contact tracing. So, Prof. Teo, maybe you can share with us, why is it still important for people who have been vaccinated to get tested? I mean, now they're talking about rolling out antigen rapid tests to more sectors, and you may need to do it before you go for a concert or for a wedding. So is this still really crucial if, let's say, we get everyone vaccinated?
I think in the short term, before we manage to reach the stage that everyone is vaccinated, this is likely to be what we will have to do in order for us to resume our mass gatherings or our weddings, concerts, our large-scale activities where there may be hundreds or even thousands of people coming together. But I do suspect that if our vaccination uptake is able to reach a sufficiently high level, then some of these requirements may be lifted, especially if the same happens worldwide as well. Because to be honest, this is a constantly moving space. And while I like to think that in the long term, we will rely almost entirely on vaccination to protect individuals and the community against COVID-19, and for us to lift almost all of our restrictions, including mask wearing, the truth is that it does depend also on the coronavirus, like what Professor Ng has mentioned. Because if the science clearly shows that the present vaccines, perhaps with additional booster shots, works very well to protect individuals and the community from hospitalizations or any long-term health impact if one is infected, then we are really starting to see that the most we're dealing with will be asymptomatic infections or very mild symptomatic infections where the symptoms are like fever, flu, cold, that typically goes within a few days or a week. So then I think there is really hope. And what we don't want is the scenario that Professor Ng was talking about, where new variants of the coronavirus will emerge, and that may significantly reduce the effectiveness of some of this vaccine. So I suspect in the short term, before Singapore has achieved that level of sufficient uptake of vaccine across the whole population, we will need to rely on expanded testing and also expanded ways of contact tracing to keep individuals and the community safe.
Thank you, Prof. Teo. So, I mean, personally, what are your thoughts? Do we need to shut more fire doors in order to keep the current outbreak under control? Do we need to enter a full circuit breaker? Earlier, you called this phase that we are in now a circuit breaker light. Do you think we will need a full one?
So right now, I think we do have much more stringent measures in place compared to April, especially with respect to border control, with the additional restrictions around dining in, around social gatherings, and also trying to get more people to work from home as default. And these restrictions, I have to emphasize, have actually reintroduced quite a lot of economic hardship to many retailers and eateries and others who rely on daily wages, such as taxi, Grab drivers. But the good news, it seems, is that the sacrifices, the cooperation of the people seem to be helping the current situation. And the number of daily cases that we have started falling from the highs of 20s and 30s a couple of weeks back to now tens, and hopefully it will continue to go down, including for unlinked cases as well. We see that there is a downward trend. So this clearly suggests that the additional measures that we put in place have been working. The additional testing, the additional ring fencing, even against a current more transmissible variant that we have right now, the B16172 variant. And I hope that this trend continues for the next 2 weeks without any other freak super spreader event. I think PM also talked about it yesterday. Then I suspect we will be in a very good position to lift some of these measures come 13th of June, but probably not all at one go, but in phases like what we have always been doing previously. So I'm not going to jinx it by saying anything about whether we will need another circuit breaker this month or in the future or at some point in the future, but let's hope we never have that.
I'm sure many people are keeping their eye out on the community cases as well. So, I mean, like, let's turn this conversation to something that's a bit more forward-looking. So, even as we continue to learn to live with this particular virus, experts elsewhere have warned that more pandemics could emerge or more viruses could come out of the woodwork as mankind continues to poach wild animals or deforest wild spaces. Professor Ng, you head up a new A-STAR initiative, the Infectious Diseases Labs. Maybe you can give us an overview of what this initiative is and how it could prepare us for Disease X.
Thanks, Audrey. Now, A-STAR set up the Infectious Diseases Labs, short form ID Labs, on April 2021. And the intention is to coordinate disease-specific efforts in A-STAR that have been built up over the years. So we aim to nip any emerging pathogen in the bud before it can cause an outbreak. So the ID Labs will actually complement and support PREPARE, the National Research Program for Epidemic Preparedness and Response. So one of ID's Lab's immediate focus is also to understand and control COVID-19. Now, through multiple collaborations with other institutions and laboratories, studies will also include tackling the ongoing mutations of the virus and the potential to impact on virulence and also vaccine effectiveness. Now, together with our clinical partners, such as NCID, ID Labs is also examining whether the COVID-19 vaccines are effective in the Singapore population, given our unique genetic makeup of various ethnicities. So besides responding to the ongoing COVID-19 pandemic, so one of A-STAR's main focus is also to prepare for outbreaks in the future, especially in our increasingly globalized and densely populated world. We know that new infectious diseases are emerging more frequently. So this ongoing COVID-19 pandemic is just the latest in a series of new infectious diseases. So some of the methods of the ID Labs would begin with clinical surveillance with our partners to monitor for emerging pathogens that could cause diseases and a pandemic.
Thank you, Prof. Ng. Dr. Sun, was wondering whether you would like to chime in here. I mean, at Cris, you focus a lot on translational research from bench to bedside, right? Laboratory bench to clinical translation. Maybe you can tell us a bit more about your work at Cris.
Sure. Cris stands for the Consortium for Clinical Research and Innovation Singapore. It is a consortium of 5 research programs and platforms. In clinical research, in medtech development, in cancer, in precision medicine, as well as in cell therapies. So each of these in turn, I guess, plays some parts in our potential fights against pandemics. SCRI, for example, one of the business units, actually has been supporting some trials at the NCID. These were in the early days where there were some therapeutics like remdesivir, for example, some of the monoclonal antibodies. So SCRI does support clinical research in that space. NHIC, another of our business units, was responsible for helping to fund some of the efforts in diagnostics in the early days for COVID. And then the cell therapy, there were one or two efforts then looking at whether some of the cell-based interventions could be useful in recovery for severely ill patients. So there is involvement in the business, some of the business units in the direct activities related to COVID research, in the last year or so. But beyond that, I think Cris sees ourselves as being a facilitator to help the ecosystem build up resilience, build up capabilities to support research during pandemic times.
Thank you, Dr. Soon. Earlier, Prof. Ng, you mentioned about the importance of surveillance, keeping an eye out on the region for pathogens circulating. And I guess for the current outbreak, we are seeing how our neighbors are also tightening their borders. Malaysia also recently called a lockdown. So Prof. Teo, maybe you share with us what is the importance of keeping an eye out on what's happening in our region and how that could affect our own public health policies.
Well, I think if we look at what's happening in Malaysia, that's a very good indication. The relationship between Singapore and Malaysia is what I would refer to the Chinese phrase, 唇亡齿寒, that we are so close economically and in many aspects of our daily living that we don't even realize or think too much about it. But Minister Gan Kim Yong has to come out and say that our supply of food, vegetables remains stable, despite the fact that Malaysia is starting their MCO, their Movement Control Order, which is the equivalent of a total lockdown today for 2 weeks. And it's not just that, because if we look at Singapore's labor movement, quite a lot of our reliance on foreign labor do come from our neighbors in Southeast Asia as well. So the relationship that Singapore has with our Southeast Asian neighbors is clearly important and very strategic, to the point that I would say there is some degree of reliance that Singapore has on these countries. So it's not just COVID-19. Even before COVID-19, Singapore has always adopted a much more forward defense approach, looking at what's happening in our neighboring countries, especially in terms of infectious diseases, whether it is Nipah virus in Malaysia, whether it is dengue in Thailand, in Vietnam. All of this can have an impact on what happened in our country in Singapore. So this surveillance must happen. And in fact, I'm very pleased that the research funding landscape has identified pandemic preparedness and resilience as one important aspect going forward. And that's why we now have the PREPARE program that has been funded and supported. And under the PREPARE program, it really allows us to have multiple components, of which regional surveillance for infectious diseases is actually part of it as well. The regional networks, the ability for some of our colleagues in Ministry of Health to pick up the phone and call someone else in their counterparts in Thailand, in Malaysia, in Indonesia, to find out what is happening in their country, actually is a very powerful tool for forward surveillance, to find out how do we protect Singapore by helping other countries protect themselves in the first place. And secondly, I think it's really, if we look at the vaccination rollout that is happening in some of our neighboring countries, there is some cause for concern because some of our neighbors are struggling to access viable vaccines to be distributed to their population. And that means they will be at a much slower pace to reach a level of comfort that we can start to open our borders for travel or for movement. And I think all of these are areas that we have to keep an eye on to help them, because at the end of the day, it is not just about helping them. It will help us both in terms of managing our community cases and also our economic reliance on neighboring countries.
Talking about vaccination campaigns worldwide, there have been some questions from our readers. As you know, we are streaming this panel live. Dr. Soon was wondering whether you can share what are the commonly encountered myths about vaccines that you have come across, and what would you say to people in order to convince them otherwise?
Okay, so I think one of the key concerns about the vaccines, and particularly now that we've opened up to the adolescents, right, the children, is that how safe are they, right? Fundamentally, they've been developed very quickly in the space of under a year. They've gone from the sort of discovery stage all the way through to clinical deployment, right? And so, basically for vaccines and drug development, usually it takes quite a while because you are doing things in stages sequentially. You're looking at the early stage in the lab testing, you're going to animal testing, then you're going on to human testing stage by stage. And that's a typical timeline because there are commercial considerations. You don't want to commit too much until you're pretty sure that the earlier stage is clear, right? Before you commit to a very expensive, a big phase 3 trial, for example. But in the case of COVID, what happened was that this was a very truncated process whereby many things were done in parallel. So, for example, in the Pfizer vaccine, even at the point when they were running the early stage clinical program, or even before they started that, there was already some sense of commitment that they were going to manufacture this at scale. All right, so Pfizer had gone out, they put together resources, they've found partners, and they started to scale up their manufacturing capability in anticipation that they will get approval for launch. So in fact, that's what they did. So these are some of the reasons why the speed of development has been so fast. The toxicology packages also have been standard. They haven't been in any way shortcut. So what we understand with regards to the safety profile, both in the animal, both in the cellular systems, and then as you come to the early phase 1, phase 2, I'll say these were top-notch studies. So the safety is quite clear. What is certainly lacking, and this is where I think some questions have been raised, is do we know the long-term effects, side effects of these new modalities, like the messenger RNA? Now the question is that you won't get long-term data until you've used it long-term, clearly, right? However, I think when in drug development, there's several ways of looking at what are the potential side effects. One is that you look at the mechanisms. So we know messenger RNA. If you understand how it works, it's basically like if you go to a restaurant and you make an order with the waiter, and the waiter takes a note down on a pad, and he says, okay, you've ordered this for your starter, this is for your main, and this for your dessert. So these are instructions that is written down on a notepad, and these instructions is passed on to the kitchen. The kitchen then cooks up your meals. So imagine the mRNA to be that notepad with those instructions. There is very volatile. It's there to serve a specific purpose. You generate the meal. In this case, would be the spike protein, and then those notepads, those little pieces of paper, are then destroyed, or they're basically thrown away. So there's no real lingering effect of this. So the mechanisms of messenger RNA are well understood. The biology is well understood. So with that, you begin to draw certain understanding and certain, I would say, conclusions about what the safety effects might be from these types of vaccines. Then the other way to look at it is then you do big population studies, right? So you're looking at it from the other end of it, where in clinical trials, in this case for Pfizer, it's in about 17,000 patients who actually received it in the trials. And you look at it and you say, look, what are the side effects that came up? And so some came up quite clearly. Those typical ones for vaccines, like pain in the injection site, some redness, some fever, fatigue, so forth. Those are the standard reactogenic reactions to vaccine dosing. And so you say that's fine, it's acceptable. But then you look for things that are a little bit more strange, unusual, for example. And in this case for Pfizer and Moderna, there really weren't many that came out to be very notable. Okay, so having said that, as this is now launched into general usage, several hundreds of millions of people have already taken this 2 mRNA vaccine in general usage. And so then there's a surveillance has kicked in the US, in the UK, in Singapore. And through this surveillance, we will pick up sort of subtle signals if there are any. And I think so far it's been pretty safe in general usage.
Thank you, Dr. Soon. But as per yesterday's announcement, we have heard that other kinds of vaccines may also be approved here in Singapore, even though this may not be completely validated, or like the 2 mRNA vaccines. Will there be any issues if people were to opt for those on the WHO's list when they become available in Singapore?
So my understanding is that under the special access route, again, these are limited use cases, right? And it has to be with consent of the patient. And then it's brought in this case, by, I would say, the private sector. So the private hospitals or the healthcare entities who may want to do it. And so it's, I would say, it's a little bit of balance of risk versus flexibility, I would say. In these cases, what the MOH has said is that we will allow for you to bring this in, but these vaccines have to be approved by the WHO under the emergency use listing, right, UL. So there is, I would say, some semblance of an authority having looked at this from the safety, efficacy, as well as quality standpoints. So the two of the three, which is the AstraZeneca and J&J, have been approved, for example, in some of the major regulatory regimes already, like the UK, J&J in the US. And so I'll say that there's good backing from the major regulatory bodies for some of these EUL vaccines. So Sinopharm is the third one that the WHO has approved. Sinopharm is quite broadly used in many countries. So I would say that WHO, I think, is a credible body with regards to assessing vaccines. And so in this particular situation, I think Ministry of Health is saying, look, it's out there, it's in general usage. I think there's a good authority behind some of these vaccines already. So let's open up a side route, if I can say that, to allow this to come in for some people who desire to use these vaccines, to use them instead, instead of the mRNA ones.
Okay. Thank you, Dr. Soon. When we talk about vaccines, we are always talking about generating immunity. And Professor Ng, there's been a question from a member of the audience about what do we know about immunity against the virus so far. I think in the earlier stages of the pandemic, people were saying that, oh, we're not really sure how long the protective immunity from a vaccine will last. Has there been any developments in the science of this area?
Yes, I think that's a very good question and very relevant question. So if you were to, when we were assessing the immune responses of the natural infection last year, we actually found that most of the patients actually generate protective antibodies. And among them, the IgG, what we call the immunoglobulin G antibodies actually could persist all the way even up to a year. And of course, right now we are 1 year, a bit more after our first pandemic, our first outbreak last year. So we are still assessing the data, but preliminary data shows that yes, there are still detectable levels. Now, in terms of the vaccinated individuals, so there have been data from other cohorts from other countries that have already gone on ahead of Singapore. They showed that all the vaccinated individuals would also generate protective antibodies. Now in Singapore, there are preliminary data. We have been following some of this part of the whole vaccine monitoring drive. Also, more than 97 to 98% of the vaccinated individuals actually will generate antibodies against the S antigen, which is actually the target of the mRNA vaccines.
So the S antigen is
as what we had discussed earlier, once you are vaccinated, you will actually generate the protective response.
Okay, just to clarify, the S antigen refers to the spike protein of the virus?
Exactly.
Okay.
Yes.
So another question from a member of our audience is, why is it that for SARS, which also was belonged to the group of coronaviruses, we managed to eradicate it within the span of a few months, whereas this particular coronavirus, which is a close relative of the one that caused the 2003 SARS outbreak, seems to be here with us to stay. Prof. Ong, you're also one of the scientists who were studying the SARS coronavirus back then. What are the differences that you are observing?
Well, that seems so long ago. Clearly, the SARS in 2003, even though it belongs to the same family of viruses, from the way it has been evolving, it is, it's been fairly different now. There have been different schools of thought, in terms of the the way the virus has attached to the host. So clearly for the SARS in 2003, it is actually a lot more lower respiratory infection compared to the current SARS-CoV-2. So that could be one of the reasons why the transmissibility is also different. Now, but then I have to also point out that in terms of the disease severity, it is also very different. I think SARS-CoV-2 comparatively, it's a lot more mild. In most of the healthy individuals. So, it's slightly different. Even though it's the same family of viruses, it will actually doesn't necessarily mean that you will have the same clinical outcome.
So plenty more research to be done, even though they are from the same group of viruses, their characteristics are so different. We have one more question about...
I mean, it is still a respiratory infection. Yeah.
Okay, yes. Thank you. We have one more question about vaccines. Dr. Su, someone pointed out that the authorities have mentioned that very few vaccinated people will develop severe illness or will require hospitalization or oxygen. But there are cases of vaccinated people who do. So the question is, how would I know if I'm one of the unlucky ones who would develop disease even though I have been vaccinated? Are there studies done into seeing, are there any markers, biomarkers that would determine whether someone is predisposed to this? Dr. Sun, maybe you'd like to take this.
Actually, I think probably Prof. Ng will be quite good to talk about this. I think maybe I'll just chip in a bit here first. The vaccine coverage seldom is 100%, right? So different people will react a bit differently. Others, some will have a very robust response. Others, either because they're ill or they've got a particular immunocompromised situation at the point in time, may not mount such a response. So it's true that the breakthrough may occur. Some people just don't mount a proper response. So I question this has been a subject of quite a lot of study, where we've been able to deliberately take blood samples from people who are before vaccination and post-vaccination to track how their antibody response goes. That has been done in some way in Singapore, but also overseas. And then those who actually do fall ill, maybe severely after the case of vaccination. I'm not aware of a case in Singapore just yet, but nonetheless, I would say this would be good patients to study if they consent to do so. So if we are able to take some blood samples from such patients, we'll be able to maybe make some determination as to why they failed to be protected even after vaccination. Maybe Prof. Yeah.
Yes, thanks, Danny. So I think you have actually given a very good summary already. So just to add on, I think every individual is unique. We're all unique. We're all different. So while a typical vaccination would generate a protective response, as I mentioned, we will develop the protective antibodies, and then later on you have your T cells that are protective. But there will be some individuals where, they might have some other previous infections that is not related to COVID, that might sort of interfere the immune response from behaving the same way. So that might have some kind of impact there. And also it could be among different reasons. I think at this point, as what Dr. Soon mentioned, we have been following some of these vaccinated individuals, and actually most of them sort of respond pretty similarly, but that could be a small number that may not actually react the same way. And I say it could be due to other conditions that is not related. But most of the time, it would actually protect. And even for those that had the vaccine breakthrough, these are the individuals who also more or less suffered a very mild, very mild symptoms that were explained by Prof. Teo earlier. So in other words, it could still actually manage the whole infection in a much simpler manner compared to someone who is actually not vaccinated.
So
Maybe
now,
Audrey.
yeah, sure, go ahead.
Yeah, maybe I will add on to what Prof. Ng and Dr. Soon has mentioned. I think if we look at what has happened in Singapore's case, that out of those that have been vaccinated and were infected, I believe the number is there are 93 infected people as of today that have been previously vaccinated and have gone through the sufficient number of days for us to believe that the vaccination should be effective. So 93 of them have been infected. But out of this 93, only one of them actually require more intensive medical care to the extent that they need supplemental oxygen. And so that's 1 out of 93. So even for those unvaccinated, the percentage of people who require medical care is actually not very high. It is about 8%, 8 in 100 people, 8% will require some medical attention that requires to the point that they need supplemental oxygen. So I think this is the first message. So you're comparing a statistic of, for those that are unvaccinated, about 8% of them will go into a stage, will progress to a stage that they require more intensive medical care. But for the vaccinated one, it's about 1%. So 8% versus 1% for those vaccinated. Now, for that one individual that we have seen in Singapore that was vaccinated, but subsequently got into quite a severe stage of infection, that individual regrettably does have some prior conditions that put that person at a weaker state to combat the COVID-19 infection. So that's some of the background that we need to understand. And if we look at what we know so far in terms of what are the conditions that puts one at a higher risk to be hospitalized, to require supplemental oxygen, or to go into a more severe stage, it is generally whether someone is struggling with a chronic condition, is obese, smokes. There are all these conditions that we know about that predisposes people to be hospitalized. And those predisposition, I would expect to be very similar for the vaccinated people as well. So vaccinated people, by and large right now, we see that most of them have very, very mild or completely no symptoms at all. That one person that we have seen so far out of 93 had more severe symptoms because that person actually had some prior conditions, prior health conditions that predisposes that person to a more severe infection.
So basically, protective immunity is multifaceted, but the chances about getting vaccinated would increase your chances of better recovery.
It actually significantly reduces your chances of having a very severe infection. And being vaccinated, so far, not just our local data, but international data, especially from the United States, where they have vaccinated more than 100 million people, clearly suggests that vaccinated people, even if they're infected, very mild symptoms or practically no symptoms at all. And I think that is a very important message for us to remember, because that is exactly where we're aiming for in terms of our long-term game plan on how we exit this whole COVID-19 crisis that we are in right now.
So thank you very much for the most enlightening discussion today. And this ever-changing virus could be here to stay, and Singapore is taking steps to deal with this eventuality through testing, contact tracing, and vaccinations. Today we heard from our experts on the importance of getting people vaccinated and to prevent the virus from mutating further, and also on the importance of future studies on the virus. I know there's still a lot of questions out there, but I'm afraid that's all the time we have for this afternoon. For more on COVID and the new normal, join me and Senior Health Correspondent Selma Kalik for a chat on the Clubhouse app at 5 p.m. Stay updated on the latest on COVID-19 in Singapore and around the world at straitstimes.com. Thank you.